We are all set now. A very warm welcome to this episode of Thursday Musings. We'll be talking about treatment aspect of catatonia. This Everyone will be on the mute mode. Questions are invited in the chat box. The session is being recorded to be put on YouTube later on. There is also a summary that the speaker has provided to us, which will be shared after the session. So, without further ado, going forward, next slide, please. Handing over the session to the chairman of this program, Professor Dr. Tofan Pati, sir. Sir, over to you. Please unmute, sir.
Thank you, Dr. Lim. I must submit that I am through a meeting like last time, but I shall be listening to all that is being transacted. And my hearty compliments to our vibrant moderators who have worked since the beginning and also now, Dr. Lim Siddiqui, Dr. Amrit Patadoshi, and please glass over the slides, Dr. Vishal Chabra and Dr. Shobit Kar. Welcome all. And I have the pleasure to introduce our chairperson, Dr. Mahesh Desai. He's a consultant psychiatrist from Surat. He did MD from BJ Medical College, Ahmedabad, diploma in psychiatry from BJ Medical College, Ahmedabad. He is director of Soch Institute of Mental Health, 34 years of experience in clinical practice, ex-assistant professor, Government Medical College, Surat, ex-assistant professor, honorary psychiatrist, Masakti Hospital, Surat, ex-superintendent, Kasturba Sivasana, Mental Health Institute, Maroli. Welcome, Dr. Desai. Next slide, please. Shreya, next slide, please. Dr. Anup Vincent, welcome, sir. Deputy Medical Superintendent and Professor and HOD of Psychiatry, SNIMS, Chalaka, native of North Parur, Ernakulam, and he married to Dr. Smiji George, Kerala Health Services. Organizational skills, finished 2 years term as Honorary Treasurer, IPS KSP for 2018 to 2020. Was EC member of IPS KSP from 2016 to 2020. National EC member for IASP for the past 3 years and continuing. Was the Secretary of Ernakulam Psychiatric Society for 3 years. Organizing Secretary of CME 2018 of IPS South Zone. WASP Regional Congress 2018. And Member Secretary of IECSNIMS won Best Secretary Award of the year 2013-14 of Rotary International District 320 Award. Convener Indian Psychiatric Society National Task Force. Welcome, Dr. Vincent. Henceforward, I hand over the meeting to the chairpersons. One of you, please introduce the speaker.
Good evening, all my esteemed colleagues. Thank you very much for giving us this platform. You know, I will upgrade my Facebook status today to chairman of Thursday Musing also. So now I request my esteemed colleague, Dr. Subhash Chandran, to start the ball rolling and to bring us up to date with clinicians about what to do and what not to do, especially in such cases. Thank you. Mike, we hand over the stage to you, sir.
Someone to introduce Dr. Subhash Chandran. Dr. Anu, could you please introduce from the CV, bring screen and the screen?
So Anub is not seem to be there.
No, sir, that's okay. Can we just cut to the chase and start the presentation? That's all right. Yeah. I think
Sure,
it's been displayed for a minute now. Yeah.
We can. So I'll over to you.
Yeah. I'm trying to share my screen. Please let me know once it's visible and sir, is it visible now?
Yes.
Yes, sir.
And am I audible?
Yes.
Okay, all right. So thank you very much for inviting me back to Thursday Musings. It's a wonderful space to be in. I mean, kudos to the organizers for coming up with such nuanced and critical evaluations of the subject. And 218 is a fantastic number. I wish you 500 and 1,000 going forward. And thank you again to the organizers for being brave enough to invite me back so soon. I just presented on November 7th, and they've invited me back to present again. I would like to see it as a vote of confidence and also bold optimism from the organizers as well. But that notwithstanding, let me dive right in. So I've sort of titled this topic as all tests normal and patients not, simply because it's sort of a common statement or a thought that comes to our mind, especially if you're looking at early career psychiatrists as well. We commonly encounter this in our ward, in our OP, in the emergency, where the most tests are normal, routine tests are normal, but the patient is just not doing okay. And that sort of epitomizes the enigma of catatonia and the delicate interplay between what is visible and what is obscured. And that's what I'm going to take you through today as well. Of course, my exploration into catatonia in this Thursday Musing started on November 7th. So here's a quick recap of it, where on November 7th, I spoke about a lot of the signs and symptoms of catatonia and how do we unmask and unravel these signs and symptoms. And that presentation involved me taking you through a clinical examination of a model patient with catatonia. And I took you through different signs and symptoms that he had. You know, some of the ones highlighted in red here are some of the prominent physical stigmata of signs and symptoms that this particular patient, Mr. Reddy, had. And we discussed this case. We looked at the different spectrum of catatonic symptoms there. We used a video where a couple of my PG colleagues were able to demonstrate some of the signs and the symptoms and how to go about examining it. If any of you have missed the presentation, it's available on the Thursday Musings YouTube channel, and you could have a look at it as well. So building from this particular foundation, today in part 2, what I hope to cover is the etiological differentiation and how do we tease out the differences between causes of catatonia. Is it a psychiatric cause? Is it neurological? Is it something systemic? Because what I want you to do is to shift the perspective and look at catatonia as a window into looking at broader systemic and physical causes. That's something that we are not really trained very well at. Yeah. And then of course I will slide on to treatment of resistant catatonia, because when you see systemic and neurological causes, most of the times you encounter a lot of treatment resistance. So if I have to break down today's presentation into further parts, I'll start off with the story of a teenager that we saw who had stuporous catatonia and then quickly switched to malignant catatonia. Now, the epiphany here is that catatonia has always been clinically conceived to be of two things: catalepsy, mutism. But in reality, catatonia is a much more broader phenotype that consists of excitement, agitation, fear, emotional responses that coexist synchronously with things like mutism and catalepsy, etc. And I'm going to show you the complications of iatrogenic complications of not recognizing catatonia earlier and what are the long downstream consequences of it. I'm going to slide then on into what are the other medical conditions that often underline catatonia, what are the things that look like catatonia, mimic it, but are actually not catatonia. Then going on to what are the predictors of treatment resistance. Is there any way when you see a catatonic patient, are you able to forebode and forecast and say, here we are going to encounter some treatment resistance. And finally, I'm going to end with some of the newer agents that are available and how to use them in treatment of catatonia as well. So just to briefly disclosure, I've taken informed consent from the family and assent from the teenager for this particular presentation. And in terms of confidentiality, I've changed the child's name so that, the privacy is protected. But mainly, this is going to be the focus of the presentation. Large part of things are available in textbooks in terms of treatment and things like that. And we are all very intuitively and reflexively and culturally, based on where we train, so used to identifying catatonia in psychiatric causes. But when it comes to the emphasis on identifying it in organic catatonia, it's slightly more difficult for us. In fact, it's considered a graveyard for most psychiatrists across the world. I mean, if you go to some of the US universities, they will tell you how difficult it is to delineate organic catatonia. It is very challenging and it is a very ambiguous area for us. And the number of complications, including the risk for mortality and morbidity, are much more higher. So a large portion of my presentation is going to focus on organic catatonia as well. So I'll start with the story, and bear with me with the story because I'll take you till the end of this presentation with bits and bits of the story throughout. Remember, this is a real case that we saw this year who's continuing to follow up with us. Yeah. So let's call this boy Akash. He's a 16-year-old boy. He in February and April, he presents with academic decline. His concentration is poor. He's constantly worrying about exams. And he also has feeling very tired, very exhausted, finds that he's worrying more than usual, a lot of crying spells, more withdrawn than usual, and he himself sort of requests for professional help. And he visits a local psychiatrist who starts him on clonazepam as well in May of 2024. Now, going forward towards the end of May, despite the clonazepam, he's still unable to sleep and he's feeling tired throughout the day. His motivation and drive is also reduced and a lot of self-doubts, which he's not used to. He's a very bright and an articulate kid working towards getting into IIT and JEs, and he's doing really well. I mean, he's passed with flying colors throughout his schooling, but suddenly has a lot of self-doubt, worrying, and a little more irritability for trivial triggers as well, especially at home. Now, in this context, he goes on in June first week to develop poor appetite with episodes of vomiting and all the previous symptoms that I said, including irritability, including the lack of motivation, they just worsen. But they visit a doctor, it is treated like acute gastroenteritis, and some symptomatic treatment is given by June 2nd week. Now that gets better, the GE symptoms gets better, but here we see him, Akash, in June 2nd week, he suddenly develops hearing music in his head, very elementary, very partly organized auditory hallucinations that happens, and he feels like people are whispering to him. He isn't very clear about what the content is, but it's happening to him. And he also feels that people are constantly talking bad about him. There's suddenly a word finding difficulty that's happening. His memory isn't as sharp as it used to be, and the spurts of irritability continue. Going forward, second week of June again, he visits the same local psychiatrist again, a private psychiatrist who starts him on risperidone 1 mg BD. Clonazepam is again, which was HS, is now made BD. And despite this medication, all the symptoms persist. And he now develops stiffening of his body, staring, mutism, and abnormal facial movements. So here are the first real signs of catatonia that you're seeing. Going forward, this is third week of June. The stiffening and the posturing worsen. It is diagnosed to be a catatonic cluster, and the risperidone is increased to 4 mg. He's now admitted to a private psychiatric ward. And what happens is, because this aggressive treatment of catatonia, the lorazepam is given through the parental route, and it's gone up to 12 mg. But there's a lot of normal blood investigation. All the routine investigations are normal here. The EEG is normal here, and a diagnosis of severe depression with stuporous catatonia is made at this particular point. But things continue to slide downwards. He now develops orofacial dyskinetic movements. Now, imagine being stiff and completely, in a very static position, a lot of posturing, not a lot of movements at all. I mean, I remember when we took back the history, the PG who took back the history, remembered the parent wishing at least the child should move a little bit more. Now, from there, he fluctuated towards severe agitation, which led to an ICU admission, and things continue to get worse. Because of the agitation, haloperidol was given. It did not work, did not mitigate the agitation, and this was followed by midazolam. He continued to be non-responsive, extremely aggressive, and needed physical restraint. But then again, catatonia takes a change in form. From stiffening and posturing to a lot of agitation, now we are looking at malignant catatonia with rigidity, fever, and autonomic instability. So, of course, at this point, if somebody was looking on, the clinical status of this child can be described as all available tests are normal, but the patient is not. And catatonia is literally being defined to parental lorazepam, considered the gold standard for catatonic treatment. This is the best way to describe this current clinical status of the child. But let me take you to a little bit of theory here. Let's just move away from Akash for a bit and look at the theory here. One of the things that we need to understand is catatonia is not a monolith. Catatonia often is an overlap between different types of presentations. And these presentations could be stuporous catatonia, excited catatonia, malignant catatonia. But there is an interface between the different types of catatonia, as you can see here. If you look at it here, in this particular case that you just saw, stuporous catatonia quickly became malignant. And one type of malignant catatonia is neuroleptic malignant syndrome. You also have types where you have excited catatonia fluctuating with malignant, and that intersection or juxtaposition is often referred to as delirious mania or Bell's mania. And it's important for us to understand the dynamicity of this model and not think of catatonia as only being a stupor state. It could also coexist with other forms as well. Yeah. So it's critical to treat catatonia quickly. I think I emphasized this in the part 1 of my presentation, where time is of an essence. The longer you delay the treatment, the longer you take to recognize, higher morbidity, higher mortality. This risk of mortality is extremely high when you think of malignant catatonia, like Akash has, like a child who I just described has. And the mortality rate, based on which study from which region of the world you read, is around 10 to 20%. And there's a high, there are a lot of conditions that can get complicated without us doing anything. Sometimes it's beyond our control. With catatonia, the little bit of a worry is it's iatrogenic harm. Sometimes either missing the diagnosis or delaying treatment or giving inadequate dosages or not recognizing the type of catatonia. Of course, when it progresses into immobility and withdrawal, there are a large spectrum of complications that can arise. I mean, we can all picturize that the picture of the photo in Mayer Gross of the cachexia patient with catatonia, with catatonic schizophrenia, where catatonia was initially described. So the complications could also be in the shapes and forms of renal insufficiency, a lot of cachexia, cardiac arrest, a lot of breathing difficulty because of immobility, deep vein thrombosis, pulmonary thrombosis, so on and so forth. There's a host of complications that can occur, which are mainly physical complications that can occur, which are very, very threatening, and the recovery period can be extremely protracted. So let's come back to Akash. So I've taken you through what are the complications, and here I'm just emphasizing why it is so important to recognize catatonia and Akash very quickly. Remember the fluctuations. So now we are in July, so he still continues to be in the ICU. The neuroleptic malignant syndrome is recognized. Bromocriptine has been added, enoxaparin as well. Now again restarted on lorazepam and high doses of THP as well. The net effect of this is the rigidity improves, but you see a lot more of a delirious picture, and it's a drop in saturation as well because of the benzodiazepine. This is a very, very common complication we encounter when we aggressively treat catatonia as well. What happens next? This is the first time we see him. So at this point, he's shifted from outside of the ICU from a private hospital to our hospital where we work. And here he's intubated because of the saturation drop. He's given a course of antibiotics as well and a seizure prophylaxis as well. But the delirium does not stop. And you've seen him being managed with haloperidol, midazolam. Nothing really helps. So dexmedetomidine is started at this point. Lorazepam and THP are stopped. So when we do the blood work for him, when we do a lot of investigations, remember the first time, please keep this in mind, all his tests were initially normal in the outside hospital, but here we're looking at a week into the illness, and here the blood investigations have changed. Of course, when you look at the CPK, it's now, which was 1500, is now reducing. Serum ceruloplasmin is negative. The first EEG was normal, but the second and third EEGs are on day 3 and day 7 are showing different patterns. The MRI brain is also showing some abnormalities, which is further consolidated with the PET CT looking at areas of hypermetabolism as well. The CSF panel is showing autoimmune antibodies that are positive. The urine drug screen and other serology is negative. Let me just take a moment here to then talk you through why we make a diagnosis of autoimmune encephalitis for this kid. So this kid who presented with depression initially, progressed to florid catatonic symptoms, stuporous catatonia, then fluctuated and waxed into malignant and excitatory catatonia, has these investigations which are strongly suggestive of autoimmune encephalitis, which are a delta brush pattern in the EEG, the diffuse leptomeningeal enhancement that you see in the MRI brain, and of course the PET CT showing metabolic changes, the pleocytosis that you can see in the CSF analysis, and most strongly and possibly the most pathognomic is the anti-NMDA being strongly positive. Again, stay with me on this because I'm going to take this and then sort of tell you what are the other possibilities here. Here, this catatonia, which we thought as an organic etiology, ended up becoming autoimmune encephalitis. That is the etiology of the catatonia here. But there are several other conditions where you can have similar presentations where it is very, very common. This is a delta brush pattern that you can see. This is in this particular patient, But if you look at, this is a delta brush, by the way, the EEG, which is very pathogenomic of it. But if you look at other literature, you can see very extreme delta brush pattern, which is very, very rarely seen in actually in clinical practice. And that's simply because by the time this patient reaches you, so many medications have been tried and so many contaminants have come in that so many of these medications also disrupt the EEG architecture that you're looking at. So it's very rare to actually get an extreme delta brush. This delta brush is much more common. So his catatonia starts getting better. His catatonia starts getting better now only with immunosuppressive treatment. And this is a word that I will use more frequently as I go on in the presentation. But for now, Akash, who was not getting better at all with anything, finally starts responding to immunosuppressive therapy. As you can see, the steroid didn't work. In fact, the steroid caused a worsening of sensorium. It caused a worsening of psychotic symptoms. The immunoglobulins didn't work. Rituximab, a modulator, didn't work. And finally, you have plasma exchange, which causes responsiveness. And that is the first time that is catatonic symptoms start resolving. I mean, if I had to describe this long story short, a 16-year-old presents with catatonia. Catatonia gets fails treatment of antipsychotic, benzodiazepines, a lot more symptomatic treatments, and finally responds to plasma exchange therapy. I mean, that is the bottom line here. So there are a lot of red flags lines that we need to keep in mind for autoimmune diagnostics, especially when you come to terms with, I mean, when you need to think of looking at an autoimmune panel, just like in Akash's case. So when you see a very, very early onset of psychosis, a lot of multimodal hallucinations, especially polymorphic hallucinations, a lot of rapid onset of and progress of psychotic symptoms, a rapid onset of catatonia. When you see a teenager or an elderly person with rapid onset of catatonia, please think of an autoimmune pathology as well. Cognitive deficits that are out of depth and out of proportion to the psychiatric illness. You saw how within a week of developing the depressive symptoms, a boy who had very good cognitive reserve, who was functioning really well, had such bad memory deficits like in Akash that you saw. Yeah, a past history of any other autoimmune disease like Crohn's, psoriasis with catatonia should also raise the blinkers to make you suspect a autoimmune pathology. Yeah. So if you look at other clinical stigmata, Frank, in the last slide, I spoke about more of subthreshold symptoms, more of very quasi symptoms that are there, quasi psychotic symptoms like in Akash's case, who had elementary or partly organized hallucinations. But sometimes when you see frank neurological symptoms also, along with psychiatric symptoms, please think of an autoimmune etiology like seizures, a lot of speech difficulties, a lot of orofacial dyskinesias and other movement or involuntary movements, bowel and bladder incontinence, etc., or any ovarian teratoma. Whenever you see ovarian teratoma, please think of an autoimmune pathology as well. So the other differentials that you need to keep in mind, especially, see, these are the investigations we did for Akash, remember? And one thing that you really need to keep in mind is when you see a case like Akash, who comes with such stuporous or posturing, stiffening, then going into excitation, try to think of other causes as well. For example, NMS alone can present like this, notwithstanding an autoimmune pathologist. Independent NMS can look like that. If you're seeing a lot of dystonic movements, a lot of choreathetoid movements, and you're seeing a lot of psychosis presenting in second decade, third decade, you could think of Wilson's disease ceruloplasmin to rule out. Epileptic encephalopathy is really interesting because it's very, very difficult to diagnose catatonia in epileptic encephalopathy. There are a lot of case reports across the world. We have seen a few cases, and there are cases across the world of Dravet syndrome, Lennox-Gastaut syndrome. You'll see temporal lobe epilepsies, where you will see when you get these seizure clusters, when you get a rise in temperature, when you get seizure clusters, that is when you can see catatonic symptoms. The other place where in epileptic encephalopathy you see catatonia is where you get interictal psychosis. There are epileptic encephalopathies does increase the risk for psychosis, and when you see that interictal psychotic period, catatonia could be a primary manifestation of that psychotic picture as well. Of course, you're looking at space-occupying lesion, demyelinating lesions, multiple sclerosis included, APLA, SLE, mitochondrial diseases as well. Please mind you, especially when you see young people with fever and this thing, and then, everything starting off with a sense of inflammatory signs and fever, and then catatonia happening, please think of a post-infectious encephalopathy. And it can also be an acute episode of gastroenteritis as well. We have seen a few cases of herpes simplex encephalitis. COVID was an excellent example of this. In fact, COVID had this complication in children and young adults called MISIC. It's multi-inflammatory syndrome in children. And when you had that, you could see catatonia as a primary manifestation. In fact, if you look at herpes simplex encephalitis, there are a lot of complications of it. One complication is this famous Kluver-Bucy syndrome. When you see Kluver-Bucy syndrome, sometimes because of the infectious encephalitis, you have catatonia also, and simultaneously and synchronously, you have things like hypermetamorphosis, hypersexuality, which makes it very difficult to differentiate from excitatory catatonia. Of course, a CSF panel and autoimmune panel becomes very important, especially in cases of autoimmune, but also look at urine drug clean for substance-induced psychosis, other toxins, looking at other viral seasons. Dengue encephalopathy and catatonia is another set of case reports that are coming up. If you look at from 2022 onwards, you can see a lot of case reports of dengue encephalopathy and catatonia. Yeah, so these are some of the common differentials of organic catatonia. So there are a lot of other medical conditions. One thing that we have commonly learned, and something that I think all of us screen for, are endocrine issues, especially thyroid. Thyroid encephalopathy and thyroid myopathies and all of the thyrotoxic Hashimoto's thyroiditis with catatonia is something that is known. Please keep in mind drug administration and withdrawal as well, especially when you look at things like cocaine, methamphetamine, and now cannabis. Now, more than cannabis withdrawal, cannabis administration can't result in catatonic symptoms. You'll see a lot of symptoms in a lot of case reports, but it is not with natural cannabis. There is this specific group of synthetic cannabis called spice. Spice, it's called K2, I think, in some places. That synthetic cannabinoids have a higher risk of causing catatonia than most other things. But please remember, any catatonia that you see, all the numbers tell you 20% of them could have an organic basis. But when you see catatonia of sudden abrupt onset, nearly 50% of them will end up having an organic cause. But I started off this presentation telling you my focus is going to be on organic catatonia, and here are some of the reasons for that. Organic catatonia is simply very, very difficult to identify. One is that it has a very, very heterogeneous presentation. It presents atypically. Think of Akash, the boy just I told you, it's very, very atypical, isn't it? And there are no specific biomarkers. This is a particular condition that requires a lot of investigations, MRI, EEG, autoimmune panels, and CSF. And we all, on the basis of good etiquette and being good practitioners, unless we have a very high index of suspicion, we are not going to order evaluations like a CSF or getting somebody pricked from the back or looking at an MRI, which is not affordable to many across our country. So the threshold for ordering such investigations, which can then lead to confirming an organic basis of catatonia, is not something that we naturally or intuitively do. One of the major reasons I find is the lorazepam response that we misinterpret. There is this saying, and there is this going, or I don't know if it's a platitude or the right word for this, but there's a lot of assumption that when you do the lorazepam challenge test and when you see a positive response, that means it is a psychiatric cause for catatonia. Nowhere in any book or at any point in literature is this mentioned. But somehow over the years, a lot of people have harbored this belief that if you see a positive response to lorazepam, think of it as psychiatric. Please remember, even if it's an organic cause, sometimes lorazepam challenge test, you will see rapid responses. Yeah, I will come to this again later on in the presentation. We must also take note that we have a lot of time constraints in acute settings, whether it is an emergency or IP, because of the time pressures that we feel, and looking at from a lot of government hospitals. Think of it from hospitals that see 200 psychiatric patients a day. The focus has to be sometimes on symptom control rather than exploring potential organic etiologies, though they might be aware there might be an organic etiology. And the final truth is there is a lack of training in organic etiology. There are a lot of good centers where psychiatry residents and early career practitioners get a neurology exposure. They get to go to a neurology department, and all the medical list of causes that I elaborated, they're able to see catatonia in some of them. But imagine a psychiatry resident who has never gone to a neurology posting, has never been able to identify the collateral symptoms of the neurological sequelae at all. How is he or she going to be able to identify an organic etiology? So these are some of the very real world practical and pragmatic difficulties that come across in diagnosing organic catatonia. But if you had to take away one, and this is an important slide here, if you had to, when do you suspect? If somebody asked me a question, okay, you have catatonia, you have all the similar, you told me, overlapping symptoms, but are there specific red flags that makes you think, okay, this could be organic catatonia rather than functional catatonia? It could be in atypical age. That could be very young children, or in terms of the elderly. Lot of treatment resistance, like you saw in Akash, not responding with the antipsychotic, 4 mg of risperidone. He's on the SSRI, not responding to lorazepam. Or like him, who's worsening with the antipsychotics. Frank neurological symptoms like or localizing or lateralizing signs that like I discussed. Lot of atypical cognitive and behavioral changes that are there, like disinhibition, manic symptoms and things like that. Already having a past medical history of say SLE or connective tissue disorders or a mitochondrial disorder or a lot of genetic syndromes that are already there in the past. Autonomic instability that comes with catatonic symptoms. And when you see waxing and waning, catatonia appears, goes. Or you see, like Akash, stupor that is now alternating with agitation. But please remember, it is not one red flag. It is a group of red flags. Usually in organic catatonia, these things can cluster together rather than occur in isolation. I won't go into a lot of the psychiatric conditions of catatonia. Like I said, you all know them, but just keep these 3 points in mind. One is that for you to really understand the etiology, for you to understand what is the underlying disease causing it, sometimes you actually have to first treat the catatonic symptoms on the surface. You must be able to mitigate it and clear it out before you see what's beneath the catatonic symptoms and identify whatever is the underlying etiology that it could be. Please remember, lorazepam resistance itself should be a trigger for you and should make your blinkers on suspecting any underlying organic conditions. Catatonia, there's a lot of debate about this. If you see, I'm sorry for the spelling, but if you look at the catatonia itself, there's a lot of schools of thoughts across the world that if you see catatonia itself, and if you're confirming it as organic, it's good. You're able to identify it's organic. But it could also mean the underlying organic condition could be a more severe presentation. The prognosis could be poorer. You're looking at a long period of recovery, and longitudinally you're looking at the propensity of various other complications arising. So catatonia could also be a predictor of the course of the illness itself, is something that you need to keep in mind. So this is a story of April Burrell. I don't know how many of you have heard of it. So April Burrell is a woman who was in a catatonic state for 20 years. I mean, there are many words that are used for this, like coma, for example, etc., etc. But she had all the frank symptoms. Remember, in the part 1 of my presentation, I took you starting from verbigration to excitement. She had all those frank catatonic symptoms and then became extremely stuporous. Now, 20 years later, a doctor in Columbia University is just going through her records as part of research. And this particular doctor, Dr. Sander, I think the name is, finds that April Burrell actually had dermatological lesions and skin lesions just before she actually went into this catatonic state. And a frank psychotic state also preceded that. And at the same time, her ESR was elevated. And when he goes back and actually looks at the tests and actually realizes she could have had SLE, and SLE could have been a cause of the catatonia. SLE is treated, she recovers from the catatonia. Now, I know it sounds all wonderful and beautiful, but this is also part of an emerging set of case series arising from across the world of catatonia occurring in SLE. There's a lot of evidence for it, especially when you look at neuropsychiatric SLE, things with lupus headaches, as they're called, like sudden onset of headaches, skin-based lesions, a lot of fatigue, lassitude, and then suddenly going into catatonic symptoms. Try thinking of SLE the next time. And in fact, it's not just tuberous catatonia like you saw in April Barrel. There's also a high risk for malignant catatonia as well when it comes to SLE, something for you to keep in mind. I also said at the very start, I'm also going to take you through conditions that can be mistaken for catatonia. Now, this is not lorazepam resistant. So if you hit a patient with these conditions with 24 mg of lorazepam, you can go to 18 mg, 24 mg, you are not going to see a response. These are conditions like stiff person syndrome, when you're looking at progressive encephalomyelitis, Parkinson's disease, all the Parkinson plus syndrome like the Steele-Richardson-Weber syndrome, like the progressive supranuclear palsy mentioned here, or in terms of drug-induced dystonias. I mean, I've had a case where somebody has diagnosed catatonia when he's been getting haloperidol 20 mg daily without any THP, and is so stuporous that they believe it's catatonia. So you see, these are the conditions that can look like catatonia, but aren't catatonia, and something that we must teach our residents and be aware of as well. Yeah, I will share the detailed differentiation of it in my synopsis notes for you to look at in terms of how do you differentiate each of these from catatonia as well. Now, I am a child and adolescent psychiatrist, and I will swerve towards children because I feel it gives you an excellent way to understand this resistance of catatonia and the pathophysiology of catatonia and why it arises. See, we all have to use paradigms to understand catatonia or any other psychiatric phenomena. And this time, I'm just, for the next set of points I want to make, I'm just using children and adolescents as one reference paradigm to explain certain features of catatonia, especially treatment-resistant catatonia. So I'll start with this. Now, this is a case report that I myself published. This is one of our case reports from our team that's there in a particular journal. As you can see, we're talking about, this is not the same case that I presented now. It's a different case from a few years ago who had autoimmune encephalitis, and it started off with a prodrome of depression. Now, the one word that I did not use in the entire case report is catatonia. The idea that some of these symptoms, because it shows you the challenge of differentiating negative symptoms from catatonia. A lot of negative symptoms that can happen in the prodrome here, it is very, very difficult to differentiate it from catatonia. The entire case report has gotten published without me using the word catatonia, but in the report, in the discussion, when you read it, you'll realize the patient had frank catatonic symptoms. And catatonia can sometimes, like in this case, be the first symptom, or in some cases, it could be part of a protracted prodrome. And do not assume that catatonia will appear first or then neurological symptoms will appear, because it could easily be the other way around. In fact, the French have a term for this called the fluctuant neck magutor, which basically means catatonia is one such thing that can appear, can disappear, and it can reappear again. Interestingly, in this case, after she got better with the immunotherapy, the catatonic symptoms got better, other symptoms got better, made a full recovery, went back to school, went into college. 2 years later, she presented again. And when she presented, the first sign that she presented was with, if you can guess, catatonia. It was the first red flag. Before any other symptom appeared, catatonia was the first sign suggesting a potential relapse of autoimmune encephalitis. Now, this opens another box, doesn't it? Thinking of, could catatonia be a predictor of other neurological conditions and other neurological sequelae, especially like autoimmune encephalitis? That's a different perspective that we need to think about. So just to rest my case again, there's a belief, the incidence wise, I mean, look at this is a very large sample that's published in the British Journal of Psychiatry. And it looks at, in that particular cohort, 86% of children who had the NMDA encephalitis had catatonia. And symptomatic treatment with lorazepam, just like in Akash's case, like I said, was absolutely ineffective. So what helped? In this particular case, again, the only thing that really helped was immunotherapy. So we are again connecting the dots, aren't we? We know of all of these treatments of lorazepam, benzodiazepines, antipsychotics, etc. in catatonia, but what really seems to improve catatonia in a very overt neurological condition like autoimmune seems to be things like immunotherapy and correcting the underlying etiology, which then raises your question, can immunotherapy be used in other cases of catatonia? Is there an immune basis for catatonia and in terms of the symptoms that we see? So can we use immunotherapy even if it's not autoimmune encephalitis? It's a question that's worth looking at, and I will end with that as well. So here again is another case, and here I want to make another point here, where this is another sample this time from the United States, where you see a lot of children with catatonia again. But if you see, nearly 90 or 99% of them had actually a neurodevelopmental disorder in the background. So the dots that are connecting here is, if you have a neurodevelopmental disorder, it could be autism, it could be intellectual disability like in the sample, the risk of catatonia is much more higher. And therefore, if you have a neurodevelopmental disorder with catatonia, you also find this pattern where the response to benzodiazepines is even worse. And they also, again, required things like ICU admissions, very severe delirium, excitatory catatonia that required infusions of midazolam and dexmedetomidine, just like Akash in our story that I started with. There are further examples of this from across the world. Here is another larger sample. This was published just a few weeks ago, where they're looking at 165 children with catatonia, and nearly more than 50% of the population had neurodevelopmental disorder. Again, poor response. Catatonia, neurodevelopmental disorder, sudden onset, rapid progress, poor response to benzodiazepines. There's a pattern developing there. And 15% of this responded only to ECT. There are many etiological bases for this. I won't go into that today. But the one thing I want you to remember is what this group did. They went back and they said, we had a lot of teenagers who we diagnosed with schizophrenia. Now they are young adults. Now, can we actually go back and look whether do an antibody profile in them? When they did it, they actually found in the previously diagnosed cases of schizophrenic catatonia, lot of them actually had NMDA receptor encephalitis and started responding to immunotherapy. Yeah. Again, we need a lot of replicative studies. Very small observational studies are, of course, not enough. But I'm just telling you that there is a wind blowing in a particular direction here in catatonia across the world. Here is a case snippet, again, to make a very important point. So we have a 21-year-old who, like Akash, has presented with a lot of behavioral changes, agitation, academic decline. The MRI and all the other blood tests are completely normal. So here also, Akash's CSF was positive, but here his CSF and serum autoimmune panel, this particular boy's is negative. Again, not great response to around 16 mg of lorazepam, and ECT was necessary for the resolution. This brings up a very important point of seronegative autoimmune encephalitis with catatonia. Start thinking of it in consultation with the neurologist when you see a patient who's experiencing with catatonia rapid progression of memory or speech, especially in the last 3 months. You're seeing a lot of absence of defined antibodies, like you can see, and you're reasonably excluded all the other usual suspects. Yeah, this is again something that's going to come up slightly different from Akash's story, but again, ECT did do the trick for some time, and again immunotherapy was required. Please remember, when you see seronegative autoimmune encephalitis, please look at teratomas. Please look, or the other way around, bidirectional. If you see teratomas, look for autoimmune encephalitis. But looking at ovarian teratoma is a very, very important thing when you diagnose this. So catatonia, I spoke about children. I said I'm going to use that as a reference template, but also look at catatonia in other groups. For example, in terms of older adults, there's a whole new this thing about how most of the cases, nearly 60 to 70% of the cases, could have a medical disorder, especially when you see an elderly person without any past psychiatric history presenting with catatonia. Try and think of an organic cause as well. And please make sure to use benzodiazepines at lower doses, and I will discuss discuss the alternatives in the treatment part. Women in the perinatal period is another sensitive group. The only thing I want to make is don't hesitate to use lorazepam, but if you're having to use lorazepam more than 4 mg, please consider ECT, and please ensure that those who are on lorazepam for catatonia women are not breastfeeding at that point of time. And after ECT, there is this certain myths in certain groups that breastfeeding should not happen, which is not true. There's a lot of scientific evidence it must be restarted immediately. Yeah. I don't know if you know this, but it's been 150 years since catatonia was first described. Now, this is a nice paper published this year in the World Journal of Psychiatry, looking at all the aspects of 150 years of catatonia. And when you look at the management algorithm of how do you actually treat catatonia, forget treatment resistant. When you start with the initial one, the classical one well described is the lorazepam challenge test. So you have 2 mg of IV lorazepam. You usually wait for 30 minutes to see a response. Sometimes you see a dramatic response, which is referred to as the Lazarus effect. But how can we predict resistance to lorazepam? Like I told you in many of the case studies or many of the ancillary reports that I showed you previously, a lot of population is resistant to lorazepam for catatonia. So how do we know before initiating treatment, could this be a resistant patient? Now, there are a few studies. I have just taken an Indian study because it's more local, more close to home, and more relatable if you look at the pharmacogenomic aspects of it and think of it from that lens. So out of the 107 patients in the NIMHANS group here, 99 actually received lorazepam and 8 received ECT as the first line. But nearly 67 of them did not. 67 of them after 99 who received lorazepam did not respond at all. So they actually looked at what could be predictors of treatment response. Can certain symptoms predict it? And they found that if a patient with catatonia had mutism, had third-person auditory hallucinations, and had a lot of those MAID phenomena, they generally had worse response or treatment resistance to the lorazepam. But if vaccine flexibility was there, that's usually one of the catatonic clusters that improves better with benzodiazepine. So this is again going to individual symptom profiling and just a good bedside test, which can guide your treatment decision into starting a benzodiazepine or not. Again, there's a lot of other questions about which benzodiazepine. We know benzodiazepines are the first choice. This again is one isolated case report from NIMHANS, which looks at clonazepam in catatonia and looking at, because lorazepam is considered, like I said, the stereotypical gold standard and used intuitively across the world. But what the authors here make a case for, and this is something that even the Western literature is now supporting, when you see patients with catatonia in mood disorders, is it and even mood disorders with psychotic symptoms, is it better to try and think of using a benzodiazepine like clonazepam that has an additional serotoninogenic effect, especially on something like 5-HT1 and 5-HT2, and could modulate GABAergic activity? Of course, we need better placebo-controlled trials, we need longer periods of observation, but just stick on to this thought of something that we have assumed long back, that within the benzodiazepines, lorazepam is the gold standard. Now, that rubric that we have thought might not be as true as we initially thought it, and there might be a certain profile of patients where we might have to, instead of doing lorazepam challenge, we might have to start off with clonazepam, we might have to start off with diazepam, something that we really need to think about. So ECT is the second line treatment, considered definitely as higher success rates than lorazepam. I'll show you the numbers. But when you choose ECT, when you usually feel that a patient with catatonia has not responded to benzodiazepines for around 3 to 5 days. In malignant catatonia, it's good to start it early, within 24 to 48 hours. And when you feel a person is not tolerating benzodiazepines, especially respiratory depression, which can be a very difficult and a very nagging side effect to deal with, ECT could be an option. Sometimes in frank overt psychosis, where you see a lot of agitation coming through, there also you can think of using ECT as the first line. But please remember not to overuse the ECT in catatonia as well. Most guidelines say, this is from the British guidelines, that says in catatonia, stick to it twice weekly. And the number of sessions that you continue to do, for how long you want to do, really depends upon the individual risk profile, side effect profile, and of course, most importantly, the treatment response. So this is a review of evidence. This is one of the largest studies looking at catatonia and the response to benzodiazepines. And you can see at an average, the response rate for benzodiazepines in catatonia is around 65%. Now, again, a very, very large trial looking at ECT in catatonia, almost as you can see, very similar conditions, similar controls. They looked at 564 patients with catatonia, and they have found the response rate to be much, much, much more higher, 76.8, while compared to the benzodiazepines, which has a response rate of only 65%. Yeah, something for you to keep in mind. The other common thing is antipsychotics in catatonia. We know it's been used so commonly, and some of the drugs that are used are aripiprazole, clozapine, olanzapine, risperidone, and ziprasidone. But the idea is to try and avoid typical neuroleptics in the first generation, especially high dosage, being very quickly given, not spaced out a lot, because that can worsen catatonia. And like you saw in Akash's case, it can lead to malignant catatonia where the risk of mortality is very, very high. But the only caution that I would have here is that, and most guidelines say this, is the antipsychotic medication should be avoided when there is no underlying psychotic disorder. I see this as a child psychiatrist a lot. I see children, I have seen children with autism, with catatonia, and have seen them being pumped with antipsychotics. And it doesn't really help. Even before a benzodiazepine trial, because it becomes more difficult to manage a child with autism and other comorbid neurodevelopmental disorders or a mixed neurodevelopmental disorder, being totally loaded with antipsychotics at very high dosages, leading to several other complications. So please be careful and mindful of how you use antipsychotics. It is to and it is to combat psychosis. So if you're not seeing psychosis, be very wary of using antipsychotics for catatonia. A few other agents that I will quickly go on to. Again, a lot of details are mentioned in the synopsis that I will share, the word file I will share in the end. Amantadine, memantine have been used because they work on the dopamine and the GABA modulation, and they have been trialed across the world as well. But the only thing is it's very difficult sometimes because amantadine causes a very nasty dermatological thing called libido reticularis, and that is sometimes not very easy. So it should not be your first line. In that synopsis document I give you, there is an algorithm of when to use what, but I would gently suggest that amantadine and memantine should come mostly as fourth line or fifth line. The other thing that's been used around the world, the newer agent, is minocycline. Again, this is pointing back to this immune pathology in catatonia and in terms of the using of antibiotics, which is not just happening in terms of catatonia, even in depression, minocycline, and schizophrenia, minocycline has been trialed. And it's not been trialed alone, it's often combined with higher potency antipsychotic. But a lot of these cases have experienced medical complications. And be very, very wary when you're using minocycline. But if you're working with the physician and you see a patient with pneumonia, with catatonia, and they sort of ask you which is the antibiotic you might want to go to, think of minocycline is the point I'm trying to make. Anti-epileptics has also been trialed for catatonia, and we have three of the stalwarts here in terms of carbamazepine, valproate, and topiramate, very tried and tested drugs. But if you see lorazepam response, then carbamazepine will work. One caveat for you to remember is you're already seeing lorazepam resistance. Don't trial carbamazepine because most studies say it's unlikely to work. Valproate is also especially good when you see this condition in excited catatonia. It's very, very good, considered to be good as an add-on to an antipsychotic or as an independent monotherapy as well. It's a good agent with good evidence and a good safety profile as well. And of course, topiramate, be very careful. Again, topiramate, it's very tricky because you need high dosages for you to be able to establish control with catatonia, and you might have to go to 100, 150, 200 mg, etc., which is slightly tricky because there's no established evidence for how long you need to maintain carbamazepine or the anti-epileptics after starting it for catatonia. There's a lot of evidence for benzodiazepines. When you withdraw, how do you taper down? But for these, that same level of evidence is not there, especially for topiramate. So it's literally anybody's guess, and you're using your clinical discretion to decide when do you want to actually taper this off. The other thing, which I just put it up because it's being used but should not be used, is carbidopa and levodopa. And especially it's being used in 25 mg from microdosing to giving a full frontal dose of 100 mg. And you see a lot of improvement in catatonia. But Same time, there is a lot of worsening of psychosis that happens simultaneously. And the suggestion is please don't use carbidopa and levodopa for catatonia yet. There is a question raised, can we start it under the cover of a good antipsychotic dosage? But that again causes a lot more EPS and is not known to protect a psychosis being precipitated. Yeah, so keep that in mind. The other one that's used, especially in mood disorders when you see catatonia, especially treatment-resistant depression with catatonia, etc., is methylphenidate. And you use it only when the benzodiazepines are ineffective or contraindicated. Though it can be used as monotherapy, using it as an adjunctive to antipsychotics or an antidepressant is considered to be much, much better. These are some papers that I will provide you that lists out some of these agents and how to use them. TMS, RTMS, and deep brain stimulation, lot of evidence in terms of evidence emerging recently in terms of how it works on the corticostriatal and the cortical subcortical circuits and improves the or stabilizes the GABAergic pathways and makes it better. But again, something that we are still very understudied. So if we sell this, it is still very undercooked and more evidence will be needed before you start recommending TMS as part of a standard algorithm. But also when you have the option of ECT to recommend TMS over ECT in catatonia specifically becomes extremely difficult. So I'm not talking about ECT versus TMS here. I'm talking about the contextually with respect to catatonia, ECT trumps TMS and it is very difficult to be predictive of it as of today, though the guidelines are changing and a few years from now this could change as well. The other kid on the block, something that we have all maybe underused or maybe it's being used in certain places, but across the world it's being trialed for catatonia, is ketamine. And there's a lot of evidence emerging about especially its non-competitive NMDA antagonism and how ketamine can therefore help in catatonia. And there are several case reports of this being trialed across the world. There is one nice systematic review, as you see here, that looks at how ketamine could be used in microdoses, intranasal ketamine, and how that can improve very chronic, protracted, resistant catatonic symptoms as well. But again, no clear consensus on how long we should use it for, when should we taper it down and stop. And in terms of other long-term side effects, especially in one of these, in this trial that you look at, one of the trials in the systematic review, a lot of them, though catatonic symptoms improved, there was actually a lot of dissociative symptoms that appeared. Just like how I told you, levodopa and amantadine, very good for catatonic symptoms, improves it quickly, but you have worsening of psychosis as a trade-off. Here, the trade-off could be a lot of dissociative effects. But then again, research is progressing so fast, they're thinking of, can we do this under the cover of something that prevents dissociation? Can we do microdosing of an antipsychotic with ketamine so that side effect is neutralized and we can continue ketamine? So that's something that we need to keep an eye on in terms of ketamine. So if you look at catatonia based on the condition, if you look at schizophrenia, catatonic schizophrenia is far less responsive to lorazepam. There are several studies, very good replicative studies with very good methodological rigor that tells you in catatonic schizophrenia nowadays lorazepam is not that responsive and ECT would be a better choice. But if you look at the opposite pole, the catatonic mood disorders, in mood disorders, lorazepam seems to have better response. In delirium, if you're looking at mild delirium, lorazepam is effective. But if delirium persists, consider low dose of atypical antipsychotics in combination with the lorazepam. Malignant catatonia, very, very important rule of thumb, avoid antipsychotics. ECT definitely in the end of the day becomes the first line because these take a lot of time to settle. These are my last sets of slides, especially something that is important about waxing and waning catatonia. We are seeing teenagers with this, we are seeing young adults with this who have catatonic symptoms, disappears after a low dose of lorazepam for a few days, then 7-8 months, you don't hear from them. All okay. Again, catatonia reappears. Lasts for a few days, disappears, happens again. This concept of periodic catatonia, which is in DSM-5, I mean, there are different ways in which this is in terms of nosology that's projected in terms of idiopathic catatonia, unspecified catatonia, but there are a lot of strong case reports of this emerging across the world. You know, how about idiopathic catatonic syndrome or this periodic catatonia and how it is so difficult to treat it because you don't have a longitudinal picture, you don't have a persistence of the same picture and it keeps changing. And what we know from a consensus of literature is this lorazepam and a benzodiazepine is not effective. While you can try a brief trial of benzodiazepines, please start ECT sooner than later. There's also a lot of evidence if ECT is contraindicated or not feasible, then prophylactic lithium and lamotrigine are also very good options, including starting lithium in the maintenance phase and then switching over to lamotrigine later on. Akash. I started with Akash. I will end with Akash. So we know how he had catatonic symptoms in the background of a mood disorder. It had autoimmune encephalitis, went to malignant catatonia. There were a lot of complications that happened. And at 2 months of admission, he was shifted out of the ICU into the ward, could not eat, was difficulty in breathing, lot of dyskinetic movements, dysarthria, non-ambulatory, slightly better in sleep, delirium has gotten better, but continues to have bouts of aggression and DVT. Now, please mind you, all of this happened initially because there was a delay in diagnosis of catatonia as well, and a delay in diagnosis of the etiology. Thinking of catatonia because the first psychiatrist when we spoke to, and this is not in any sense to blame that psychiatrist, because I'm sure all of you like me can empathize with that psychiatrist who saw a child with academic decline, cognitive difficulties, and in terms of poor concentration, etc., and suddenly having stiffening, mutism, not moving, thinking of catatonia and using an antipsychotic. But that 1 month delay in getting that immunotherapy made a big difference. This is him at 3 months where he's still unable to communicate. He's able to communicate slightly better, but it's not as for the functional language levels are definitely lower. There are thankfully no catatonic symptoms. He's now ambulatory with support. He has a type of confabulations that we refer to as a behaviorally spontaneous confabulations, and he's finally discharged. But it's been a long course for this boy, yeah, and it all started off and got complicated with catatonic symptoms. The one thing that we think of in catatonia, while we all go gun-ho about the patient, and in fact, a lot of modus operandi is how can we make the patient better, we must also acknowledge the elephant in the room that sometimes catatonic patients stay catatonic for a very, very long time. And that takes a big toll on the caregiver. And it's very important that we screen the caregiver. I mean, imagine a herbiphrenic schizophrenia or a catatonic schizophrenia in the ward for 3 months, 4 months. It's important that we screen for an axis 1 disorder with the family member itself. Look at the grief. Like in this case, a child who was aiming for IIT JEE, now completely non-ambulatory on a diaper and being fed by the parents and cannot move himself. Can you imagine the grief that the parents feel? I mean, grief is not just with death or bereavement. Grief is also when previous functionality is lost. And that's where a lot of psychoeducation and looking at what the family is going through, helping them deal with the burnout, connecting them to support groups becomes very important. A very important thing is also to talk to the extended family, because somebody has catatonia, they're chronically catatonic, everybody comes. And in India, though you can be a nuclear family, very practically it ends up becoming a joint family or an extended nuclear family for all practical purposes. Therefore, talking to the other members of the family also become very, very important. So this is my last set of slides. I'm going to leave you today with 3 clinical cautions with catatonia and this particular condition that I described. My first clinical caution, let's go back to Akash. Let's look at this stage in his life where risperidone was made 4 mg because of stiffening and posture, a lot of agitation, haloperidol given at high doses, and he had oculogyric crisis and malignant catatonia. Please remember that dopamine blockade can actually sometimes, especially high dosages of haloperidol, can make sometimes catatonic symptoms worse. And if it's not responding, it's time to pull back. Stuporous catatonia can very, very quickly turn into malignant catatonia when you use typical drugs. Please keep this in mind, and this is my first clinical caution. My second clinical caution comes from his investigations. We looked at how the EEG is normal prior to admission, but this is because we are using high dosages of lorazepam. Please remember, benzodiazepines can mask epileptiform activities. You look at opioids, you look at benzodiazepines, it can decrease REM and slow wave sleep. What then happens is in patients, especially if you're catatonic, you end up going to higher sedation requirements to control the agitation and the disturbances. But the higher and higher you go with the benzodiazepine, sometimes lorazepam 24 mg, 26 mg, like I've told you before, it sort of reduces the validity of some of these investigations to detect and identify organic catatonia. My clinical caution number 3 comes from where he finally improved. He finally improved when we gave immunosuppressive therapy. So when you see a non-response, please remember just dialing steroids. In fact, there is a whole set of trials that have failed where corticosteroids themselves have been used to treat catatonia separately. But when you use catatonia, when you have catatonia amalgamated with psychosis and you use high-dose corticosteroids, it can actually worsen all psychotic symptoms, including catatonia. So the catatonia can sometimes be getting worse just because of the type of corticosteroid and the dosage you have used. So you need to stop this corticosteroid as early as possible, or in some other cases, if steroid discontinuation isn't feasible, try and use a low dose antipsychotic. Finally, my 3 musings to take home from today's Thursday musings, the 218 Thursday musings. I'll leave you with 3 final musings. First one is the next time you see the scenario where you think about it, all available tests are normal, patient is not, you see catatonia and you see catatonia being very, very stubborn to lorazepam, consider evaluating for autoimmune encephalitis. Please remember it is a red flag for other autoimmune conditions. The second musing that I want to leave you with is that do not dismiss catatonia only as a psychiatric disorder. The best and perhaps the most effective therapeutic approach is to treat the underlying condition. Like in all these cases where I said immunotherapy was used, and use it in adjunct with the specific treatment for catatonia like benzodiazepines or ECT. My third musing in terms of therapeutics, which I'll quickly go, is that parental lorazepam still remains the first line. I was not trying to advocate today and trying to tell you that lorazepam is bad. All I'm trying to tell you is think beyond lorazepam when the case demands it. ECT is still very, very effective. Anti-epileptics should be considered fourth and fifth line. And please consider, if you're seeing psychosis, consider antipsychotics. The other catatonia that you see is due to clozapine withdrawal. When you take some patients on clozapine for a very long time, very quickly tapered down and stopped, catatonia can emerge where low dose clozapine reintroduction has been found to be very, very effective. Don't try levodopa and carbidopa. It worsens psychosis in most cases. In some cases, triggers psychosis. My final musing, again to keep this, is that lorazepam is still the first choice for catatonia. This is a recent article published in Schizophrenia Research, authored by one of the stalwarts in catatonia, George Northoff. In fact, you have the Northoff rating scale for catatonia as well, which we discussed in part 1. Please remember that it is very difficult for us to comment on catatonia because the clinical effect of lorazepam in catatonia is not, we don't have comparative trials looking at comparing 50 patients with catatonia, lorazepam versus diazepam, lorazepam versus clonazepam, or other atypical antipsychotics, or in terms of an anti-epileptic. We don't have such RCTs. But what is undoubtedly clear and which you cannot argue with is in the last 40 years since lorazepam has been introduced, it has been life-saving for many patients. Lot of patients who were mute have been able to speak again. Akinetic patients have been able to move again. Patients who were not able to eat and drink and do that again and within 10 minutes to 1 to 2 hours of giving lorazepam. Now, which drug in psychiatry can do that? Can you think of any other drug where, or any other conditions where you can get such rapid therapeutic effects? It is very, very rare. Lorazepam still remains the first choice, but you must use your clinical discretion to think of other options like clonazepam when need be, or ECT when need be, and don't underuse that. And most importantly, when there are indicators or directions towards organic causes, please try and detect it, because treating the underlying organic etiology is the best way to improve catatonia. Thank you.
Thank you so much, Sahas. It was really a wonderful presentation. We learned a lot. We are uh, re-enlightened because of you. Thank you so much. Over to chairpersons for their opening remarks.
Am I audible?
Yes, sir.
Was we have done a very good job. And thing is that lorazepam is the only thing we have the scientific evidence. But thing is that, as you said, we should try with other agents also. But thing is that nowadays the catatonia is not presenting that frequently in our clinical practice. But definitely, there are conditions like semi-catatonia, like the people is not talking and all these things. When we just introduce the 1 milligram of lorazepam TDS, they will start talking. So I don't know, any other thing is not replacing this thing. But I want to know this thing, organic catatonia. How we are going to manage that? Because organic catatonia, I felt that most of the times it is maybe an uh, secretary of any kind of infection or something like that. So in organic catatonia, I felt if you give benzodiazepine, the things will worsen. So I need the speaker to tell about how we are going to deal with organic catatonia.
Thank you, sir. So I did elaborate on organic catatonia for most parts, and I do agree with you. You should know when to switch off from a benzodiazepines. But most of the guidelines, and by the way, the clinical consensus guidelines for treatment of catatonia is only from one association, which is the British Association of Pharmacology. Their association, who have done the most of the studies in catatonia come from Britain today, and they are very clear. Even in organic catatonia, please trial a benzodiazepine first. But if you see that it's leading to side effects, for example respiratory depression, or it's causing worsening of delirium, that is when you need to make a shift to another alternative agent, like perhaps an antipsychotic or others. But a lot of them say if you're looking at severe organicity, ECT should still be considered there. And in a lot of conditions, ECT causes the most improvement in organic catatonia as well, rather than benzodiazepines. I showed some numbers and some averages as well. Yeah, but it is very tricky, sir, because it varies from condition to condition and organicity, and there are so many organicities nowadays that can cause catatonia. The other comment that you made, sir, in terms of not seeing many cases of catatonia, in fact, there's a lot of literature saying that whereas all the catatonics disappeared, has catatonia completely disappeared from psychiatry? If you just Google it, you can see a lot of literature. The idea is that a lot of authors argue, including George Northoff, who's stimulated the scale, and Rogers, who's made a scale as well, that it's just that the mental illness awareness has become a lot better. In most cases, catatonia used to be coming in the later stages of an illness, or when there's a larger duration of untreated illness and larger duration of untreated psychosis. Nowadays, because of better awareness and better interventions available, we don't reach that stage. That is perhaps one of the most common reasons why people feel in the clinics the catatonic these things are reducing is a nice argument to make. But like I said, there's a lot of literature on that as well.
I want to know, Suhas, there is in a relationship between the catatonia and the cluster B, like emotionally unstable personality disorder.
Yeah. So in cluster B, in borderline personalities, if you look at Bateman studies, if you look at a lot of newer studies coming across, there's this concept we have traditionally heard of quasi-psychotic symptoms or micro-psychotic symptoms in borderline personality disorder. There is a notion of thought that catatonia could also be one part of the quasi-psychotic symptoms, and the incidence is supposed to be slightly more than the general population. But again, sir, not something that is very, very well studied and longitudinally followed up, not very much. But yes, it is reported and said to be more than that of the general population.
Okay.
Of course, please keep in mind when you think of BPD, the incidence of non-convulsive status epilepticus is much more higher. And if you look at a lot of past studies, a lot of these non-convulsive status epilepticus has been misdiagnosed and reported as catatonia. Now, there the use of lorazepam has improved the anxiety symptoms of possibly an underlying neurosis, or whatever is the storm that built up to that triggered the catatonic episode or the pseudocatatonic state. So then saying that lorazepam works better there is not a true inference, but there are a lot of studies that looks at that as well.
So,
Okay, Suhas, yeah,
I
Anup,
think
sir, carry on.
it's open for discussion. I think we have to go for the chats and all, or how is it?
Yeah, we can take the questions from the chat box. If Mahesh sir wants to add, And sir, we need to learn from your experience. How have you seen this
No,
Catatonia
sir.
field evolving?
Honestly, it was an excellent presentation. And today I have moved from using dopamine blockers to a higher level. So I don't want to add anything. I open this session for question answers.
Very, very
Okay, thank you, sir.
thank you,
Thank you,
sir.
sir. Suhas, one
Yes.
query combining both the sessions and sort of a overview. You have already talked about it. So we are talking about catatonia. So we
Yes.
established the signs and symptoms with the videos that we showed. Okay. So now catatonia is there. How will we know whether it is catatonia due to bipolar, schizophrenia, or the organic catatonia that you say? So a person comes to us first time in catatonia. Now clinically, what are the indicators for being so-called organic thing that we are talking about?
Sir, like the slide that I told you, no, when you are
Yeah.
seeing a very abrupt, see, organic catatonia, if I can just show you that one slide again, if you don't
No, no,
mind.
no. I've seen the slide just for the audience
When you
recap.
see abrupt onset, when you see other atypical psychiatric presentations, when you see rapid progression of symptoms, when you see resistance to catatonia, I mean resistance to typical drugs used for catatonia like benzodiazepines or worsening with benzodiazepines and antipsychotics, that's when you can start thinking of organic catatonia. But there's a large this thing looking at, can we look at symptom analysis to be able to differentiate between catatonia that occurs in bipolar versus schizophrenia and things like that? Not very what do I say, not very supportive evidence. Some of them are very conflicting evidence. Like in one of the slides I said about waxy flexibility, I said about stupor, and whether those are more in schizophrenic catatonia than you have mood disorder catatonia. Whether excitement in catatonia is a very rare presentation in schizophrenia, but these are not replicative, sir. Catatonia has more than 50 signs that have actually been described. There are more than 50 signs and symptoms that are described. So to do a study to look at in terms of using each of these symptoms and saying, is it more predictive of the underlying bipolar? I am not aware of any studies like that.
Okay.
Intuitively, if you ask a lot of seniors and a lot of good teachers, they will tell you, like I said, no, when you see excitement is not very common in schizophrenic catatonia. It's nowadays said to be more exclusive to bipolar catatonia, things like that. Yeah, but we
Yeah.
need research, sir.
Sure, sure. Mahesh sir wants to add something.
So was why I just wanted to ask that making a mistake of adding antipsychotic drug and making a mistake of giving ECT to organic catatonia, which will be a safer bet.
It depends on the dosage of the antipsychotic. So I think if it's a low dose of antipsychotic, that would be better. But ECT, sir, I'll tell you honestly, there are so many times, and I'm a child psychiatrist, where I would have preferred to use ECT over lorazepam, sir. But I can't. I can't simply because it is very difficult. The MHRB rules are very, very strict, sir. For using an ECT in a teenager, I have to get the permission from two people, and it's going to take some time for the MHRB to respond to me. Like I told you in the presentation, catatonia is a very progressive condition and the number of complications that arise are very quick. There are so many conditions where we feel ECT can be used, but even with mild risk, the anesthetists are not willing to take it up. That's also a common problem we face in adults and in the geriatric population. And our understanding whether we can take a position there and say, no, the risk is on us, we want to go ahead despite the minimal risk that's involved. I still remember a case that Dr. Ashok, one of my teachers, saw where we had a patient with catatonia who was around 60, 62, geriatric depression, also had cancer, and very, very stuporous, could not feed, could not take anything. RT was going, the RT tube was there left and right. He actually took the risk with the moderate risk that the physicians had given, actually went to the ICU and gave ECT there. And that led to a lot of improvements initially. The patient passed away subsequently, but there is this notion that sometimes what we understand as mild contraindications, can we surpass that and still give ECT is something we need to really look into.
Exactly, I totally agree with the Suhas, because ECT is the one thing that it can be considered a last option, but thing is that most of the times the young patients, like not the child patients. If things is not working, we can go for ECT. It's not a big thing because it is a clearly indicated thing that ECT can be given. But thing is that to psychoeducate the family members about ECT and all this thing is little this thing, and that is also we have to consider that.
Okay, Shobit, would you like to take questions from the chat box? Shobit and Vishal?
Sir, first a bit, Suhas, can you actually, for the benefit of the audience, tell us about thalamic filter and its role in catatonia, and subsequently why? Because many people will think that ECT is only for functional disorders, like catatonia is secondary to functional issues, not
Yeah.
for organic issues. So in that sense, also things will be more clearer.
Sir, I think you are better placed to talk about it than I am, sir. Because my knowledge about it is it's very low, sir. I know that there is this entire thing of thalamocortical relay cells, and I know that in terms of the catatonic states, there is a whole point of that. And a lot of treatment-resistant catatonic cases are because this network is not hit. That's a TRN network, or I don't remember exactly. I think it's called the TRN network, which is not targeted because none of the traditional medications target, and ECT doesn't help with it. But I think, sir, you might be able better position to add on to that.
See, actually, to put it very simply, there is an issue of thalamic filters in catatonia, and then the functional disorders and the so-called organic disorders, they actually bring up this deficit, which can be reversed with benzodiazepines, and I think, as Suhas said, all the other strategies. But which will work in whom
Yeah.
is little tricky. So that is.
Because that was the whole notion, because one of the reasons and old etiologies for catatonia is thalamic hyperconnectivity. And the idea is benzodiazepine sort of reduces that hyperconnectivity, if I remember right. So that way it works better. But how do we profile and how do we get these biomarkers is very difficult.
In continuity with this, there is a question in the chat box. It's a case-based scenario that there is a 45-year-old woman with recurrent periodic catatonia with a background of bipolarity, multiple indoor admissions, each time responded to parenteral lorazepam, but again, the relapses occurred despite lithium risperidone and oral lorazepam being continued in the follow-up. No history of fever or seizure. Investigations are normal. So, like, how to go about it? You address it in your presentation. Just can you actually revise it for us?
No, this is becoming a more common thing. In fact, I think I don't know who this doctor is, but it's a very good choice to put lithium in these cases, especially if it's in the background of a mood disorder. There's evidence that prophylactic lithium can actually reduce the further incidences of catatonia, especially periodic catatonia. But if lithium has not worked and you have had 2 failed trials of it and the person has again had catatonia despite an adequate dosage, lamotrigine is being investigated, and lamotrigine has shown a lot of positive results in preliminary studies, and its effect size is considered to be better than that of lithium. So lamotrigine could be tried in this particular patient. Of course, please be careful with the dermatological things and etc. But lamotrigine, I think, is a good option in the case you said, sir.
I had a point to make about this. Whenever the lorazepam is given, try to give in the either minimum of 3 times dosage or 4 times dosage, 1 milligram, so that it will be easy for the patient to have this thing. And it will be very slow tapering. Very slow tapering of lorazepam will affect. Don't do a drastic kind of stop and these things. So that's why 1 milligram 4 times daily. Then after 1 week, 3 times, then 2 times, like that. That will help the cataract symptoms a little bit more. That's my experience with the patients.
So this is a question in the chat box also, which Dr. Anup Vincent has actually addressed. Partly, how you actually taper the benzodiazepines, Suhas.
Yeah. Sir, I've just shared a nice synopsis on it, and the British guidelines are very good. You can just follow that. Yeah. But like Sir said, the essential principles are taper down slowly. don't taper it fast. We have seen cases where you go from 8 mg to 0 mg, and that causes, see, benzodiazepine withdrawal catatonia. There are two types of withdrawal catatonia that are very famously known. One is a clozapine withdrawal catatonia, and second one is a benzodiazepine withdrawal catatonia. And the principles of the BSZ withdrawal catatonia is fast reduction. So usually we want to wait it out for a few months before we take it off. In fact, if you look at the initial guideline for schizophrenia and catatonia, they had to be on benzodiazepine for more than a year, sir. The maintenance phases were very long. But now we know that the recent guidelines say at least for a few months you need to have it, and need to have it at a low dosage. But the other complication that I must add is benzodiazepine dependence. In the quest to keep it and to prevent relapse, the incidences of benzodiazepine dependence is also increasing, and that becomes another challenge. And then most practitioners are having to cross taper that with the benzodiazepine with other agents like a low dose antipsychotic just to prevent that. So that's a challenge as well. But I will share that paper. I think it's a paper that everybody should read, on the British Association of Psychopharmacology guidelines on how to use lorazepam and how to withdraw lorazepam. It's a fantastic paper that talks about challenges of tapering down and withdrawal.
There is
Suhas,
a question in the
I
yeah,
want to
Anup sir.
ask one thing is that see, benzodiazepine dependence. This was a very gray area. Most of the times say that if a person who is having a thyroid deficiency, we are giving thyroid. If a patient who is getting benefit on the benzodiazepine, and thing is that if he is not, we have to no need to increase the dosage. Then I don't feel like it's not dependence, like just like a thyroid, because patient needs that anxiety, something like generalized anxiety disorder or catatonia. If that needs, if it is we are not increasing the dosage, patient is doing well, we have to go for it. That's my thought, because we have to take the consideration of the benefit of the patient, because he is getting the benefit on the drug. If he is getting benefit on the thyroid, then expect the same thing. We have to get the thing about the benzodiazepine.
Sure, sir.
No, it's my thought. It's my thought only.
Yeah. There is a question in the chat box. Sir, can we try IV lorazepam high dose in a patient with chronic catatonic features with no other psychiatric neurologic symptoms? Any risk of worsening general condition and dropping vitals? Do require airway stabilization with intubation before high dose lorazepam?
No.
So I think my follow-up question here with, what do you mean by high dose lorazepam?
Yeah,
That's a very subjective thing, because like sir or madam has asked, it's something that's a very commonly intuitively asked question. So if you're going to say things like 12 mg, 16 mg or above, it will be good to have saturation monitoring throughout. In fact, this thing is, we shift the patient to an intensive unit where a monitor can be attached, and we're able to monitor the saturation, because yes, saturation does drop. And also thing is, don't use too much of high dose lorazepam when you're seeing delirium as catatonia in delirium, because your slow wave sleep reduces, your REM reduces, and the risk of again fragmented sleep is higher, worsening delirium, worsening catatonia. It becomes a very preposterous cycle to break. So be careful in those circumstances. But yes, respiratory side effects is something that you all need to monitor, if that is the direct answer to that question. But don't intubate before it. I mean, intubation kit and everything is kept ready, of course. That's why I said you move to an intensive unit when high dose lorazepam comes, and you intubate only when the risk is higher. In fact, that's not true only for lorazepam. Even for midazolam and all, when you use for delirium, that's the same grounds and criteria you use. You have to keep saturation monitoring, and then you have to be ready to intubate. The other one, next, dexmedetomidine, you have to do cardiac monitoring. You have to do QTC monitoring very, very frequently, because torsadus is much more higher. So be careful with that.
No, I want to add one more thing is that whenever there is, high dose of benzodiazepine, and this thing only works for if there is autonomic hyperactivity, like delirium. Delirium is a condition where there is autonomic hyperactivity, where there is increased heart rate, increased blood pressure. And thing is that the respiratory depression will not happen there. But thing is that in catatonia, if you give high dose of this thing, because there is no autonomic hyperactivity is not happening there. But thing is that the patient will go for respiratory depression. So
Yeah.
it's not advisable.
Yeah, because autonomic instability as part of a catatonic symptom is one of those indicators that you should not give high dose lorazepams.
Yeah.
Autonomic instability is a symptom of catatonia itself.
Yeah. That's why this delirium and catatonia, we should see, even if catatonic stupor itself, we should not give high dose of lorazepam, because it will work only on high dose lorazepam, work only on autonomic hyperactivity where there is delirium. There is like 5 things we have seen, like we have got increased heart rate, increased blood pressure, and increased autonomic hyperactivity, like intestinal these things, and as English galvanic skin temperature and salivation. These 5 things, if it is there, we can give benzodiazepine without any this thing. But in very carefully, we should use this thing in catatonia.
Dr. Swaz, there is a question in the chat box, like regarding antipsychotics. You already shared in your case vignette that the child got antipsychotic and there was a worsening. So if the child would have received anticholinergic, that has worsened the catatonia, because we know it can worsen the cognition.
Yeah.
But catatonia part of it, number one, and which antipsychotic we'll prefer if we talk about schizophrenic catatonia per se, like any interclass differentiation is there or not.
Yeah, so I think the first part is that high dose of THP. I think that's something that you need to be very careful about, because especially in delirium, like you said, cognitive deterioration, and especially night dosing of THP, which is a very strong anticholinergic effect, can lead to major deterioration and worsening of catatonia. It can also lead to a lot of masking, and you're not able to identify some of the symptoms of catatonia as well. But in terms of classes of antipsychotics like a present, there is not major difference. I mean, initially, I think there was a large group of studies that said aripiprazole might be slightly better. And there's also a group that said that treating the psychosis more aggressively, especially if you're looking at schizophrenia, clozapine being used earlier rather than later and treat the underlying pathology earlier, can also lead to better resolution. But as such, most of the new studies, especially a couple of new systematic reviews, does not place one antipsychotic superior to the other. But be careful in terms of first generation antipsychotics, especially high doses, and stopping clozapine abruptly, because clozapine withdrawal can also make it fairly worse. So with antipsychotics, that's my thoughts on that.
So, ask what are the lab reports one should send in such a patient of catatonia, starting from CBC?
Yes, so in that slide that I had put, like I said, no, I think in terms of you're using an antipsychotic, monitoring CPK becomes very, very important. I think when you're suspecting other, like CBC, looking for just any sort of leukocytosis can also become important. Looking for a viral picture in the normal hemogram and the blood counts. Looking at any other deficiencies also, that can be part of it, because one of the notions is that catatonic symptoms could manifest more severely in those who already have a pre-existing medical issue and deficiencies, etc. I think in terms of looking at if you're suspecting an autoimmune thing, looking at the CSF panel becomes very important. And the CSF panel is considered, autoimmune panel is considered more reliable than the serum autoimmune panel, by the way. So that's a point I was trying to make. And of course, if you're looking at serum ceruloplasmin for things like Wilson's disease as well, the dengue antigens, if you're suspecting another viral etiology, in terms of typhus fevers, leptospirosis, looking at all of those antigens in the blood becomes very, very important. But also, while I say the blood, and I've spoken a lot about EEG and MRI, and I even spoke about PET CT, it's important not to miss the basics and look at blood pressure, heart rate, pulse rate, temperature, and saturation. Because in the quest to look at all of these investigations, sometimes this routine monitoring is not done. Like I want to emphasize again, autonomic instability is one of the earliest signs of catatonia also, and it could be a sign that things are getting worse. So keeping a good TPR monitoring chart is one of the best monitoring and one of the best investigations that you can do. Of course, you need to consolidate the same with monitoring in terms of the rating scales that I said in the first part of my presentation of Bush Francis or Northoff or the modified Rogers, or whichever one that you're using.
So, how do we differentiate catonic picture from NMS, from malignant hyperthermia, and these sort of conditions?
Yeah, so that I also answered in the presentation, where I said that in terms of looking at rigidity, looking at in terms of tremors, looking at the CPK levels itself will tell you about the NMS. And catatonia as such, in terms of, like I said, NMS is considered a type of malignant catatonia itself. NMS is not considered a different type. NMS is subsumed under the rubric of malignant catatonia. And malignant hyperthermia will not have the antipsychotic history and the antecedent to that and things like that, but might have raised temperatures, etc. But blood-wise, CPK being raised and rigidity are very pathognomic signs there.
In
Thank
case, I want to add one thing. In catatonia, when we give the patient some food, they will keep it in the mouth. Just keep it in the mouth. But thing is that in NMS, what happened is that whenever you give the food, it will be very difficult for them to swallow, because the NMS, when it comes, it will be difficult that swallow this thing, that contraction and all this thing will be very high. And one more very particular thing we have noticed in NMS is that diaphoresis. Diaphoresis is very particular for NMS, not in catatonia. And also there is fluctuating BP. Fluctuating BP and fluctuating heart rate is very common in NMS. So if catatonia and NMS, and I totally agree about the malignant catatonia. This is malignant catatonia. These are the features we have seen, because I have seen a case very particular about that, and they feel very difficult to swallow. But thing is that in catatonia, they just keep inside the mouth for at least for 30 minutes or 1 hour, just keep. But thing is that for when you give this thing for the NMS, they will difficult to swallow, and they cannot able to do it because of the contraction. That's my
Yeah.
view.
I
thank you.
agree, sir, but
Thank you.
also in terms of the medical history, very clearly you will see a use of an anesthetic or a muscle relaxant in malignant hyperthermia. You will definitely see it in MH most of the times. You won't, at least the cases that I have seen, I could be wrong, but the medical history itself should, before we even get to a clinical or a phenomenological differentiation, the medical history itself will help us, what I think.
So I think we have covered all the questions in the chat box, and Suhas has been constantly speaking for us from 8 p.m. Still 100 people are there to listen to you, Suhas. So I think you have a good fan following now.
I don't know the answer to this question. There's a very
You are
interesting.
like a Rajnikant.
Yeah, by
I think
sorry,
the Suhas
sorry, I
can
missed
close
that.
off the Suhas can close off by actually telling us when to involve a neurologist. A lot of audience are single chamber practitioners.
Yeah.
Um, I think catatonia is always best dealt with as a multidisciplinary team. I think a
Yeah.
multidisciplinary team helps, and a very important component of the multidisciplinary team is a neurologist. When you are seeing psychiatric symptoms, including that of catatonia, associated with any of these neurological stigmata that I said, it could be a soft neurological symptom, it could be a soft neurological sign, like I said, about psychiatric symptoms with dyskinesias, with a lot of cognitive symptoms that are out of proportion to the psychiatric symptoms that are there, in terms of lot of movements that are there, even minor movements, minor dyskinetic movements that are there. You're looking at a past history of any autoimmune pathology or a medical history in the past, especially a past neurological history that has been there. You're looking at any sort of progressive speech related or language related deficits that are there. I would think these are the circumstances that you would want to consider involving a neurologist. And I think that the neurologist will also see, the question should also be asked the other way, and ask the neurologist also, when should you involve the psychiatrist? And if this was him, because I think that is a more important question. And I think the neurologist should involve the psychiatrist much more than the psychiatrist should involve the neurologist. Because so many causes of catatonia are neurological and they're present to the neurologist first. And the neurologist should be able to involve the psychiatrist, especially when you see, and for them, the answer will be when you see atypical psychiatric symptoms. When you saw, like in Akash, that I said, very rapid onset, polymorphic, very quickly changing psychotic symptoms. When you see things like that, and sudden cognitive decline and things like that, catatonia that is rapid in onset and rapid in progress, the neurologist should involve the psychiatrist early, is my point.
Because your with this answer, a neurologist should involve psychiatrist, so fan following has increased even more.
If I could just
Thank you.
one thing, I found a very
Yes.
interesting thing here. Someone asked about Mukesh Batra asked about lebroxant and melatonin. I actually don't know because lebroxant doesn't have evidence because correct me if I'm wrong, lebroxant works on orexin and it's a hypnotic. It works on orexin, but there is no evidence of orexin in catatonia as of now. That's a very
Yeah.
interesting question. But melatonin in COVID-19 in MISIC in children when catatonia was there, melatonin was supposed to be better. Yeah, so that's the only thing. I'm done. I'm done. Thank you.
Yeah, melatonin
Thank
is
you.
also good for that tardive dyskinesia, that kind of things.
Yeah. So thank you, Suhas. Thank you so much. Final closing comments from chairpersons, then we can move to the thanks session. Any closing comments from the chairpersons?
No, I don't have because you already finished everything.
Yeah. So Mahesh sir, your overview of the topic, your experience. We want to
So,
we'll learn from you
you
also.
see, sir, we started with, once upon a time, all catatonias means we used to treat them as schizophrenia and ECT and all that. So I was just
Yes, yes, yes.
wondering that all those patients to whom we gave ECT, how many of them may be really having these organic catatonias? I am wondering. And I wanted to ask Suhas bhai that if I give ECT to all missing organic catatonia, what will happen? That is what I wanted to ask you. We have really come a long way. We have come a
Nothing
long
will
way,
happen,
and these
sir.
days, for a busy practitioner like me, I hardly see catatonia. You won't believe. Recently, I saw one, and when I wanted to start a low dose olanzapine, my son stopped me and said, "Hey, look, old man, he sent me so many references of lorazepam, and he said that, old man, you need to catch up." So I requested Vishal that now whenever something comes up on catatonia, you invite me as a chairman.
That's
Thank
really
you.
here, sir.
Thank you, sir. Thank you so
Yeah.
much, sir.
Thank you.
So, Vishal, over to you for the thanks session.
Okay. Thank you, Dr. Alim. So first of all, thanks, Dr. Suhas, for an amazing, interesting presentation. And the energy and the passion you have for catatonia is amazing. So I thought if there's a patient of catatonia, instead of consulting a neurologist, I'll consult you because I'm not sure they will be interested in it as much as you are. So I'm very happy to see a youngster being so passionate about catatonia, which was an old thing. Everybody had thought it's old. Who's bothered about catatonia? Something like that. It's like somebody starts talking about hysteria or something. So thank you so much. Thank you to both the chairpersons for their wonderful remarks. And I'm glad Anup joined in, and Anup with his experience at the mental hospital, I think had a lot to add. So very nice. And thank you, Desai sir, for being there and bringing humor to the whole
Thank
thing
you.
and
Thank
bringing
you.
your learnings. Thank you, sir. And sir, you can
Thank
put in your FB, sir. You're twice
Yes.
chairman of, not just once, twice the chairman of
I
Thursday
am
meetings.
also.
Yes. I can't.
You are also
Thank you.
I'm a
Thank
thrice.
you. Thank you.
thrice. Okay.
Thank you.
So thank you, and thank you to my fellow moderator, Dr. Ali, for always handling it from the start to the end very well, and Shobit for his
Very good,
excellent
very good.
contributions, enriching. Thank you all the
Thank
participants.
you.
We had, I think, up to 170 plus participants and 100 till now still watching us. And also would like to thank Tufan sir and Amrit Bhai for being there always and helping us from the background. So both of them busy at the conference of East Zone, so that's why they couldn't come for the thanks. I'd like to thank also IPS Odisha State Branch, which is the founder and the main host for today's meeting. Thanks to Arun Pharma for providing us for the technical support and Zoom meeting link. Thank you, everyone. I
Thank
think
you.
now, thank you, Dr. Lee.
Thank you. Thank you so much. Thank you, Vishal. Anup bhai, thank you.
Alim
Suhas.
also, and thank you.
Thank you, sir.
Welcome, sir. Welcome. Thank you. Suhas, it was really wonderful. बहुत अच्छा था. It was really wonderful.
बहुत अच्छा.
Learning
pleasure.
experience.
Yeah.
My pleasure.
Thank you.
Nice.
Ending the meeting.